In order to perform an abdominal exam, you will need a good light source, full exposure of the abdomen, warm hands, and ideally a comfortable and relaxed patient. The patient should empty her bladder before the exam begins to allow accurate examination of nearby organs and make the exam as comfortable as possible. The patient should be supine with her arms at her side. Have the patient relax her abdomen. Place a small pillow under her head and knees. Approach patient from the right side. Place a towel or sheet over her chest for warmth and privacy. Percussion of the abdomen. Percussion is used to assess the size and density of the organs in the abdomen and to detect the presence of fluid, as with ascites, air, as with gastric distension, and fluid-filled or solid masses. First, percuss all quadrants and regions of the abdomen for a sense of overall tympany and dullness. Tympany is the predominant sound because air is present in the stomach and intestines. Dullness is heard over organs and solid masses. A distended bladder produces dullness in the suprapubic area. Percussion of the liver. Begin liver percussion at the right midclavicular line over an area of tympany. Always begin with an area of tympany and proceed to an area of dullness, because the sound change is easiest to detect. Percuss upward along the midclavicular line to determine the lower border of the liver. The area of dullness is usually heard at the costal margin and slightly below it. Mark the border with a marking pen. The lower liver border that is more than 2 to 3 centimeters below the costal margin may indicate organ enlargement or downward displacement of the diaphragm because of emphysema or other pulmonary diseases. To determine upper border of the liver, begin percussion on the right midclavicular line at the area of lung resonance. Continue downward until the percussion tone changes to dullness. This marks the upper border of the liver. Mark the location with a pen. The upper border usually begins at the 5th to 7th intercostal space. An upper border below this indicates downward displacement or liver atrophy. Dullness extending over the 5th intercostal space suggests upward displacement of abdominal fluid or masses. Measure the distance between the marks to estimate the vertical span of the liver. The usual span is approximately 6 to 12 centimeters. The span greater than this may indicate liver enlargement, whereas a lesser span suggests atrophy. Age and gender influence liver size. Liver span is usually greater in males and in tall individuals. Percussion of the spleen. Percuss the spleen just posterior to the mid-axillary line on the left side. Percuss in several directions. Begin at areas of lung resonance. You may hear a small area of splenic dullness from the 6th to 10th rib. A large area of dullness suggests spleen enlargement. The dullness of a healthy spleen is often obscured by the tympany of colonic air. In general, it is also not possible to distinguish between the dullness of the posterior flank and that of the spleen. Dullness to percussion in the trob space, defined by the 6th rib superiorly, the mid-axillary line laterally, and the left costal margin inferiorly, has been found to have moderate sensitivity and specificity for detecting splenomegaly.
Palpation around the umbilicus. Palpate the umbilical ring and around the umbilicus. The area should be free of bulges, nodules, and granulation. The umbilical ring should be round and free of irregularities. Note whether it is incomplete or soft in the center, which suggests the potential for herniation. The umbilicus may be slightly inverted or everted, but it should not protrude. Palpate the liver. Place the left hand under the patient at the 11th and 12th ribs, pressing upward to elevate the liver towards the abdominal wall. Place your right hand on the abdomen, fingers pointing towards the head, and extend it so the tips rest on the right midclavicular line below the level of liver dullness. Press your right hand gently but deeply in and up. Have the patient breathe regularly a few times and then take a deep breath. Try to feel the liver edge as the diaphragm pushes it down to meet your fingertips. Ordinarily, the liver is not palpable, although it may be felt in some thin persons without pathologic condition. If the liver edge is felt, it should be firm, smooth, even, and non-tender. Feel for nodules, tenderness, and irregularity. If the liver is palpable, repeat the maneuver medially and laterally to the costal margin to assess the liver contour and surface. Palpation of the gallbladder. Palpate below the liver margin at the lateral border of the rectus abdominis muscle for the gallbladder. A healthy gallbladder will not be palpable. A palpable tender gallbladder indicates cholecystitis, whereas non-tender enlargement suggests common bile duct obstruction. If you suspect cholecystitis, have the patient take a deep breath during deep palpation. As the inflamed gallbladder comes in contact with the examining fingers, the patient will experience pain and abruptly halt inspiration. This is known as Murphy's sign. Palpation of the spleen. The spleen is in the upper left quadrant, lying above the left kidney and below the diaphragm. Stand on the patient's right side. Reach across with your left hand and place it underneath the patient over the left costovertebral angle. Press upward with that hand and lift the spleen anteriorly towards the abdominal wall. Place the palm of your right hand with the fingers extended on the patient's abdomen below the left costal margin. Use your findings from percussion as a guide. Press your fingertips inward towards the spleen as you ask the patient to take a deep breath. Try to feel the edge of the spleen as it moves down towards your fingers. The spleen is not usually palpable in adults. If you feel it, it is most likely enlarged. Palpate below the costal margin so you do not miss the lower edge of an enlarged spleen. Remember to be gentle with palpation to avoid the rupture of an enlarged spleen. Repeat the palpation when the patient is lying down on her right side with hips and knees flexed. While still standing on her right side, press inward with your left hand to assist gravity in bringing the spleen forward and to the right. Press inward with your fingertips of the right hand to feel for the edge of the spleen. Again, if you feel the spleen, it is most likely enlarged. It is uncommon to feel an adult's spleen. Palpation of the kidneys. The kidneys are located in the retroperitoneal space of the upper abdomen. Each kidney extends from about the vertebral level of T12 to L3. The right kidney is usually slightly lower than the left due to the large, heavy liver above the right kidney. To assess the kidneys for tenderness, ask the patient to sit down. Place the palm of your hand over the right costovertebral angle and strike your hand with the ulnar surface of the fist of your other hand. Repeat this maneuver over the left costovertebral angle. The patient should perceive the blow as a thud and not tenderness or pain. To palpate the left kidney, ask the patient to lay supine. Stand on the patient's right side and reach across with your left hand and place it over the left flank. Place your right hand on the patient's left costal margin. Have the patient take a deep breath. Then elevate the left flank with your left hand and palpate deeply with your right hand. As the patient inhales, try to feel the lower pole of the kidney. The left kidney is usually not palpable. To palpate the right kidney, stand on the patient's right side. Place one hand under the patient's right flank and the other at the right costal margin. Have the patient take a deep breath. Then elevate the flank with your hand and palpate deeply with your other hand. As the patient inhales, try to feel the lower pole of the kidney. The right kidney is more commonly palpable due to its anatomical position. It should be firm, smooth, and non-tender. It may be difficult to distinguish the right kidney from the liver edge. The kidney has more rounded edges, while the liver tends to have sharper edges. Ascites may be suspected in patients with protuberant abdomens or flanks that bulge in the supine position. Percuss for areas of dullness and resonance with the patient supine. Ascites usually settles with gravity. Expect to hear dullness in the dependent parts of the abdomen and tympany in the upper parts due to the rising of the lighter bowel. There are 4 ways to assess for ascites. The first of these maneuvers is shifting dullness. Have the patient lie on one side and again percuss for tympany and dullness. Mark the borders. The borders of dullness will shift to the dependent side in a patient with ascites. Without ascites, the borders will remain constant. The second of these maneuvers is the fluid wave test. This procedure requires 3 hands. With the patient supine, ask your assistant to press the edge of her hand and forearm firmly along the vertical midline of the abdomen. This stops the transmission of the wave of fluid through adipose tissue. Place your hands along the sides of the abdomen and strike one side sharply with your fingertips. With your fingertips of the other hand, feel for an impulse of a fluid wave. Easily detected fluid waves suggest ascites. Findings here are not conclusive. Fluid waves may be felt in people without ascites or may not be felt in people with early ascites. The third of these maneuvers is auscultatory percussion. Have the patient void, then stand for 3 minutes to allow fluid to gravitate into the pelvis. Hold the diaphragm of the stethoscope mid-line above the symphysis pubis with one hand. With the other hand, apply finger flicking percussion to 3 or more sites from the costal margin perpendicularly downward towards the pelvis. Note changes above the pelvic border at fluid level. In a patient without ascites, note first a dull percussion, which changes sharply to a loud note at the pelvic border. The fourth maneuver to assess for ascites is the puddle sign. Ask the patient to assume the knee-chest position and maintain that position for several minutes to allow for any pooling of fluid by gravity. Percuss the umbilical area for dullness. The area will remain tympanic if no fluid is present. Next, elicit the abdominal reflexes. With the patient supine, stroke each quadrant of the abdomen with the end of a reflex hammer or edge of a tongue blade. The upper abdominal reflexes are elicited by stroking the abdomen up and away from the umbilicus, while the lower abdominal reflexes are elicited by stroking down and away from the umbilicus. A slight movement of the umbilicus toward the area of stimulation should be equal bilaterally. A diminished reflex may be present in obesity or when the abdominal muscles are stretched during pregnancy. Assessment of abdominal pain involves the use of several different assessment techniques. First, rebound tenderness is identified by holding your hand at a 90-degree angle to the abdomen with the fingers extended. Press gently and deeply into a region remote from the area of abdominal discomfort. Rapidly withdraw your hand and fingers. The return or rebound of the structures that were compressed by your fingers causes a sharp stabbing pain at the site of peritoneal inflammation. Next, the obturator muscle test is performed. You perform this test when a ruptured appendix or pelvic abscess is suspected because these conditions cause irritation of the obturator muscle. With the patient supine, flex the right leg at the hip and knee. Grasp the ankle and rotate the leg laterally and medially. Pain in the right hypogastric region is a positive sign. Do you have any pain? Next, perform the iliopsoas muscle test if appendicitis is suspected, because an inflamed appendix causes irritation of the lateral iliopsoas muscle. With the patient supine, place your hand over the right lower thigh and have the patient raise the right leg, flexing at the hip while you push downward against the leg. Pain in the lower quadrant is considered a positive sign. Finally, Rovsing's test is performed if you suspect appendicitis. Press on the left lower quadrant. If pain in the right lower quadrant is intensified, the test is positive.
Do you have any pain in the right side? Okay.
Assessing for the presence of a floating mass involves the use of a palpation technique known as ballottement. To perform abdominal ballottement with one hand, place your extended fingers, hand, and forearm at a 90-degree angle to the abdomen. Push in and toward the organ or mass you are assessing. If the mass is floating or freely movable, it will float upward and touch the fingertips as fluid and other structures are displaced. To perform bimanual ballottement, place one hand on the anterior abdominal wall and one hand against the flank. Push inward on the abdominal wall while palpating with the flank to determine the presence and size of the mass. This concludes the advanced health assessment of the GI system.